Yeah, dear Chairman, ladies and gentlemen, it's now my pleasure to discuss the three randomized trials, Stellar, Stellar 2 and Prime RT, that indeed have added new data to the concept of rectal cancer treatment in three aspects. First, TNT, which is primarily aiming at improving distant metastasis, watch and wait, organ preservation, primarily addressing functional outcomes and quality of life, and now with a new approach, the immunotherapy in immunologically cold tumors or MSS tumors. So what is the evidence for TNT? And we have 5 randomized trials to address TNT, where short course or chemorad followed by induction or consolidation chemotherapy plus TME plus minus adjuvant chemotherapy was tested in randomized fashion against the standard of care. 3 of these trials have been applied with 5 times 5. 2 trials have used chemorad. Now, if we concentrate on the 3 5 times 5 chemorad trials, you realize that there are major differences with respect to many aspects, including very divergent oncological outcomes. So the first Polish trial was performed in locally advanced, clinically fixed, unresectable tumor with an aim to improve R0 resectability. This trial used only 3 cycles of FOLFOX and surgery was scheduled early. There was no increase in R0 resectability, and although there were no difference in long-term oncological outcomes apart from overall survival, and here reminiscent to the Stellar trial, which however vanished away with longer follow-up. The Rapido trial was the largest of these TNT trials, and in my opinion it was the best designed trial because it focused on MRI-based advanced diseases, clearly defined with T4 and risk factors. It applied enough cycles of neoadjuvant chemotherapy. It allowed for a long time before reassessment and surgery to allow for tumor regression. And with these features, the Rapido trial showed indeed that their hypothesis of a better disease control was fulfilled, which was mainly based on a better reduction of distant metastasis. And now the Stellar trial, when you compare it with the Rapido trial, confirmed a better early endpoint respecting a complete response, and was also associated with a more acute toxicity as seen in the Rapido trial, but it was divergent with all the other endpoints. And why is this? I think there are some limitations of the Stellar trial. First, the endpoint was non-inferiority, which is probably not the best endpoint you can have, given that TNT was introduced to apply effective chemotherapy at the earliest time point and with adequate compliance, which should improve distant metastases and thus disease-free survival. The Stellar trial had rather broad inclusion criteria, T3, T4, and plus, which may have diluted the efficacy of TNT for the primary endpoint, disease-free survival. The Stellar trial primarily shows that there is an increased acute toxicity without any advantages in disease control and quality of life. So if the author conclusion that TNT is now a preferred treatment really justified when you only look to the Stellar trial. And the overall survival benefit is interesting, but there is no real explanation. Fine is that there was no increase in any acute and late complication, no second primary tumors, non-cancer related death, but it's not really a clear explanation, and it may well disappear with further follow-up as shown in the Polish trial. So if we now combine all randomized trials on TNT versus standard of care, most guidelines throughout the world, including the NCCN guidelines, the ESMO guidelines, our German guidelines, a lot of others in Europe, now prefer indeed TNT an option. But note that this is primarily based on the convincing improvement of distant metastasis seen in the Rapido trial and in the French Protige trial. So it is a new and standard of care, but you have to consider that the Polish trial was negative and that the Stella trial primarily showed non-inferiority. I think the evidence now is primarily on the Rapido-like inclusion criteria, so very well advanced tumors. You have to consider the acute toxicity with these neoadjuvant cycles, especially in elderly and frail patients. And there remains some concern with early progression in non-responding tumors with induction of fibrosis. TME quality was poorer in the Rapido trial, and this may have been the reason for reduced local control. What we need to further investigate is how many neoadjuvant chemotherapy do we really need? Is there any need anymore for adjuvant chemotherapy like applied in the Stella trial, and what is the preferred regimen, 5x5 or chemoradiotherapy? Some of these questions have been addressed in our German phase 3 trial that tested the Rapido regimen versus a optimized chemorad schedule and a reduced number of consolidation chemotherapy, now for the endpoint organ preservation, not disease-free any longer, organ preservation at 3 years. This trial has completed accrual last year, and first results will be available early next year. This brings me to the topic of organ preservation now with immunotherapy, and I think you all are very aware and thrilled by the results of this New England Journal publications in 2022 on only 12 patients with MSI positive tumors that completely disappeared after a 6 months treatment with immunotherapy monotherapy. But note, the MSI status is rare in rectal cancer and is clearly below 5%. So the question now, of course, is would TNT together with immune checkpoint inhibitors also work in the MSS patients, which are the majority of our patients? And if this is true, which regimen should be used? Short course, chemorad, which kind of TNT regimen? And which sequence of immunotherapy and duration of immunotherapy would be optimal in this respect? Now, the PRIME RT from Britain was a study that was mostly done in MSS patients, and the backbone of immunotherapy was chosen as durvalumab, starting before any treatment and then during treatment for 14 weeks. Note that the interval between end of local treatment and a response assessment was different in both arms, which may have influenced the early efficacy endpoint complete response. And there is, for me, a not really explainable large difference in acute toxicity that may be associated with the immunotherapy in the 5x5 arm. Be it like it is, the primary endpoint, so sustained complete response in PCR 6 months after treatment and with longer follow-up, was better with 5x5 versus chemorad. And the limitations of the trial are clear, small, the toxicity, compliance, timing of response, but most importantly is now the question, was the immunotherapy regimen chosen wisely when starting before any treatment and then during treatment? And this is interesting. We have a very recently published trial in Nature Med that indeed in a study population again with MSS tumors randomized between chemorad control without any induction, without any immunotherapy, and then concurrent immunotherapy or sequential immunotherapy. You see here that the compliance was excellent and there was a certain increase in toxicity, but this was equal in both trials. But only the short course, only the sequential arm in this randomized trial showed a significant improvement with respect to the control arm. And this is interesting because sequence obviously again matters in multimodal rectal cancer treatment with great impact on endpoints. The Stella 2 trial was indeed the largest randomized trial in 100% MSS patient with adequate patient numbers. You see here that, as expected, acute toxicity increased with the addition of immunotherapy, but this had no consequences on compliance of radiotherapy, of chemotherapy, and of immunotherapy. And with now response assessment taking place 20 weeks after start of treatment, there is not only a statistically significant improvement, but really this is a clinically significant improvement in early response parameters. Why is this? I criticize the STELLAR trial, but I really think that there are many strengths now in the STELLAR 2 trial. It is adequately powered regarding the primary endpoint. It has a very clear design, so the identical TNT regimen plus or minus immunotherapy has been tested. 5x5 has been used as a radiotherapy backbone, which is supported by the PRIME-RT trial, by other Chinese trials and meta-analysis. And by design, immunotherapy was here used sequentially, which is supported by radiobiology, by the POLAR STAR trial, and also by experiences in other tumor entities like the Pacific trial in lung cancer. And note, now response assessment takes place at week 20, which is now very similar to the experience in MSE patients where the treatment was 6 months and response assessment was after 6 months. So, to conclude with the ever ongoing debates of 5x5 versus chemoradiotherapy, we have now new players, new kids in the field, and new scenarios. So from the early Polish trial and the Australian trial, we know that in locally advanced tumors, T3, T4, and plus, when there is mandatory TME surgery, you can choose between both. There is no difference. The STAR Trek today showed that when it comes to organ preservation, it seems to be that the efficacy of chemoradiotherapy is superior to short course radiotherapy. However, when you add neoadjuvant chemotherapy to 5x5 and has mandatory TME, this is clearly shown to be improved and a better regimen than standard of care chemorad alone plus TME. Our German trial will show whether this changes again when chemotherapy is added to radiochemotherapy for the, again, important endpoint organ preservation. And what we learned from the PRIME-RT and the STELLAR 2 trial is that probably radiotherapy with 5x5 should or could be preferred to the long-course radiochemotherapy when it comes to organ preservation. However, of course, we have to wait long-term results from the phase 3 trial. I'd like to congratulate all trial groups, the International STAR Trek group, the British PRIME-RT trial, and especially to our colleagues and friends from China, the STELLAR and STELLAR 2. It's nice that we don't have any tariffs when we exchange our scientific approaches. So thank you very much, and congrats to the groups.
Thank you, Klaus. And that concludes the first edition of the Lancet Oncology Green Journal session and initiative. And as you understood, it will be renewed next year. And so I would like to thank the speakers.